We are going to continue with the lung part of today's meeting with the DZL presentations, and I'm happy to welcome Natascha Sommer from the Gießen side of the DZL, presenting data on the Gießen and also whole DZL Pulmonary cohort. Please, everyone, stick to the 10 minutes talk time now, because now these talks will be a bit shorter than the previous presentations, because we have 4 talks in that session. Something like 8+2 or so. And Natascha, again, thank you and welcome.
Yeah, thanks, Susanne. I'm happy to now start with the presentations for the lung area, which of course is one of the most important areas, because COVID is a lung disease. And I'm also happy that Gani already gives some introduction into our pulmonary cohort, so it will be easier probably for me to keep the 10 minutes. So now we have seen today a lot about symptoms, and I mean it's clear that post-COVID has lots of symptoms, and I'm focusing today on dyspnea or exercise limitation. We know that this is a very frequent symptom, although also fatigue is very frequent, and I will not talk today about this special form of fatigue, which is this post-exertional malaise-related fatigue, but try to focus really on dyspnea. And we as a pulmonologist department saw in the beginning lots of different patients which all complained about dyspnea and exercise limitations. And it became quite clear pretty early that these are all different patients, and it's a very heterogeneous group. And I tried to kind of categorize it a little bit. So we have these patients with coughing, with chest pain, which is potentially primary respiratory symptoms, maybe with severe COVID. Then there were patients coming mainly with tachycardia, which limited them, and patients with these neurological symptoms or with more psychiatric symptoms. And our aim in our study was to figure out if in this really heterogeneous cohort there's a common denominator, so which limits all these patients similarly, or if we can define subgroups, which was like clinically a little bit evident, where we have also specific treatment approaches. And to do this, you first have to think for a minute about how is dyspnea caused, and it's for some reason not that trivial for many also young physicians that dyspnea is not only hypoxemia. I mean, this is one component in the chemoreceptors, but dyspnea is mainly sensed by receptors, vagal receptors. We already heard a lot about the vagus today, and mechanoreceptors in the chest wall, which just sense that the mechanical stress does not fit to the brain input. Furthermore, we have to keep into account that as a cardiac impairment can cause dyspnea via receptors in the lung that sense the dilatation of the veins, and also baroreceptors. And there's also connection from the muscles to dyspnea sensation via the sympathetic nerves. So we tried to look in a more holistic approach on all these different factors. There's a lot published like on single factors, for example, like the diaphragmal weakness, but we try to integrate this somehow and try to understand which patients are caused, have the cause of dyspnea of which component. And Gani already showed you that we did this in this so-called PULMVASC study. It's a multi-center study with different centers in Germany, DZL centers, and we had a cohort of patients, a small control group, different methods, and by this we wanted to measure all these potential causes for dyspnea, which I just have showed you. And this is now something that also overlaps a little bit with Gani's presentation. Sorry for that, but he was selected for an abstract, so he presented this already. So what we found is, first we looked what kind of features does this cohort have. And what we found was that they have quite low PET CO2 in the CPET, and high EQ CO2, so it's a kind of ventilatory inefficiency. It's a very unspecific sign, can be due to hyperventilation, can be due to increased dead space, but it's a kind of objective parameter that somehow the ventilation is not efficient and efficiently coupled to the circulation. This was quite nice to see because it has been described before. So there are several publications that show that there's a ventilatory inefficiency for whatever reason. Then a second point, and there we were more surprised, was we did a deep phenotyping of the heart, especially of the right heart. Our center focuses on pulmonary hypertension and has established methods for subtle measurements of right heart dysfunction. So we thought if the right heart or pulmonary vasculature is involved in the dyspnea, we would be able to detect it by 3D echocardiography, stress echocardiography. And our initial hypothesis was that there may be an increased stress on the right heart. However, what we found surprisingly was that the right atrium and the right ventricle in our cohort with patients was relatively small compared to published normal values, but also compared to our control group. The oxygen uptake was also decreased, but this is nothing I would like to focus today. So I would like to focus on this relatively small right heart, which we thought, well, is this relevant or not? And then we did correlations to dyspnea. So because a lot is published, a lot of observations has been published, but often this is not correlated really to the symptoms of the patients. And what we saw here, this just depicts the findings with the most relevant correlations. And what we found was at first that dyspnea in our cohort, so this is the PCS, is higher if the exercise capacity is lower. So this is kind of intuitive. We found also that the dyspnea is somehow, high dyspnea is related to low lung volumes and a high peak breathing frequency. And it was also related to the size of the right heart. So here, this is the right atrium, this is the right ventricle. So this gave another hint that this may really be relevant for the patients. We also found that dyspnea was correlated to diastolic dysfunction. Or not, it's not a dysfunction really, it's diastolic function. So the better the diastolic function, the less dyspnea. And interestingly, this was also true in the controls. So this seems to be a general feature that you can better work under exercise if your diastolic function is better. Another factor that is related to this is this so-called aortic impedance index, which gives a measure for the stiffness of the vessels. Everything was related to heart rate, so dyspnea, the more dyspnea, the higher the heart rate. This was an observation we had made. Then when we did multivariate correlations, we found that the size of the right heart is still correlated to dyspnea. So obviously there is a parameter that seems to correlate, although only weakness, but to dyspnea. So I will not go focus today due to sake of time on the lung ventilation, but this is another component which may cause dyspnea. And this right heart or right atrial size, again, was correlated. So what patients are these with this small heart or small right atrium? They have a high heart frequency and they have high VQ mismatch. So this seems to be a phenotype which is described when we go to literature as preload insufficiency. Preload insufficiency means that during exercise you can't fill your right heart, you can't give enough volume to your heart, basically. We had some invasive measurements which were confirming this. This is only a small number, but we did not too many invasive measurements in patients. But we saw in the patients exactly what we anticipated, that under exercise the right atrial pressure does not increase. Obviously the preload is not sufficient. And this syndrome has been described in this nice paper as a reason for unexplained dyspnea. And it fits to our observations with this kind of VQ mismatch, what they have, positional VQ mismatch especially, and we found also some lung hyperinflation. So we believe that this preload insufficiency may be one component observed in all post-COVID patients, which contributes to their symptoms. And there are different diseases which are related to this. Then we did a subgroup analysis to see, because the correlations were quite weak, of course, but I think this is intuitive because there are these heterogeneous patients. And we thought, could we find more subgroups? And here I just want to focus on two subgroups we identified. And so there are two subgroups which have even more pronounced this kind of preload insufficiency, and they are characterized by a pronounced VQ mismatch, low blood pressure, and hyperventilation. And then there's an opposite group, which is more characterized by their dyspnea correlating to bronchial limitations. So these were like ex-smokers often. They had a high resistance of the bronchial system. And it was correlated to a pretty low diastolic function. So we believe by further subgrouping these patients, we can find distinct additional features which limit them in their exercise capacity. So we propose this kind of multifactorial causes for dyspnea and exercise limitation post-COVID, with one feature being this preload insufficiency and potentially subsequent tachycardia. Additional features in specific groups are bronchial and left ventricle limitations, so this I would call the comorbid phenotype or the endothelial dysfunction phenotype. We already heard a lot about that today. Then we have this phenotype which is more going in this direction of low blood pressure, and I would call it a POTS-like phenotype. And there is a phenotype which having hypercirculation very prominent. And for them, of course, specific treatment options would be useful. And what kind of, this is what we heard a lot about today, so what would integrate some of these alterations is an autonomic dysfunction. And here in a sub-study, we found that the sympathetic drive in these patients, in selected patients, was also increased. With that, I will probably not show where to go because now the time is gone. But I think we need to confirm this now in a second cohort, and probably even go multidisciplinary and multi-center to get a toolbox how to phenotype these patients over several centers, and then see if we really can confirm these phenotypes and treat them specifically. And there are treatment options. Finally, I think it's the aim, what many of us have, that then from these phenotypes we can define endotypes and pathomechanisms to go deeper into treatment approaches. So with that, I would like to thank all of the collaboration partners and the BMBF for funding this study, of course.
Thank you very much, Natascha. I guess I have to be here, right?
Yes.
Are there questions from the audience? I actually have a question regarding the small right heart that you identified. So can you, I mean, you already said that it's hard to correlate to something at this point, but can you speculate on what is the pathophysiological relevance of this? What are causes or consequences in that regard?
Yes. So, I mean, it depends if you have a real preload insufficiency where you also have this tachycardia, which limits the patients a lot, or if this leads to some diffusion disturbance and activation of baroreceptors, which may initiate a flat and fast ventilation. So I think it's connected via baroreceptors to ventilation and thereby to dyspnea sensation. Maybe it's it's also a cause for the low DLCO we see in the patients. So in many patients, and this is a very persistent thing, we see low diffusion capacity. And I did in the beginning a lot of ventilation, scans or CTs to figure out the low DLCO, and there was nothing. There were no lung embolism, no CTED. So this may be because the volume of the pulmonary vasculature is low, so just the blood volume is low, and this then may lead to DLCO.
Right.
Yeah. So this may be the consequences of that.
Okay, thank you. I think there are no further questions, so thank you again, and I'm happy to introduce the next speaker to you, which is Herbert Schiller from the DZL Munich site. Herbert is going to present data on autoantibodies related to post-viral syndromes. The stage is yours.
All right. Thank you, Susanne, for the introduction. I'm happy to be here to talk about one of the methods we developed in the lab. So in my lab, we focus on regenerative mechanisms in the human lung. We use kind of the experimental systems biology toolbox to look at cellular and molecular processes in lung regeneration, how that fails or changes in the aging process and in chronic lung diseases. And of course, the immune system is very important in tissue repair processes. And I will mainly touch on one method that we use to look at autoantibody profiles. So today in the morning we heard a lot about how autoimmunity seems to be really associated with post-COVID, post-viral infections in general. So this is now very well known, as shown in this very large meta-study here. After COVID-19, it was quite clear that all kinds of autoimmune diseases are increased in the after COVID-19. And in general, the risk of developing post-viral sequelae, so these syndromes like ME/CFS, they have been known before, but now the pandemic gives us the chance to study them in larger patient cohorts. And this will also be very important for maybe future pandemics. So early in the pandemic already, there were lots of reports about autoantibodies. So for instance, autoantibodies against type 1 interferons have been associated with more severe outcomes. Then there are other reports about protective roles of these autoantibodies. So it's quite unclear, but there were lots of reports. And more recently, there are first, you have correlation and causation, and there are first attempts now, first evidence, where when you transfer antibodies from patients with specific, we have heard about different endotypes of the long COVID. So patients that had more myopathy type symptoms or neurological symptoms, some of these symptoms were phenocopied in the mice when they received antibodies. So in my lab, we do a lot of tissue slice cultures, so maybe there is a chance to also study functionally some of these autoantibodies in human tissue slice cultures as an outlook. So now I will talk about what we did in terms of profiling. This was in acute COVID setting, and we teamed up with Scott Badinger at Northwestern University in Chicago. They had an ongoing study where they for a long time already studied influenza patients. So here we have very good controls because we want to know what is specific to COVID versus influenza. And we also had the bacterial pneumonia patients here as a control. And we used mass spectrometry to look at the bronchoalveolar lavage of the patients when they get intubated in the ICU. They got lavaged, and then we followed over time. So this is a longitudinal study, and also had the matched serum from these patients. And as you can see in these heat maps, those are blocks of proteins that correlate very highly over patient groups and time points. You can find groups of proteins that are very highly specific for either influenza or COVID or bacterial pneumonias, both in the lavage fluids and in the serum of the patients. And here's one example of something that you would maybe expect. This is a group of proteins that was very much enriched in the bacterial pneumonias already. So here you see two different time points from time of intubation. Oh, is that my time? No? Okay. And so you can see that this protein profile here correlates with neutrophil degranulation. So these are all proteins that are probably involved with neutrophil degranulation, and they correlate with the number of neutrophils. And here on the right side, I'm showing you one example of a group of proteins that was very much enriched in the COVID patients, and it also persisted into the later time points. And those were all kinds of antibodies. Of course, you could find antibodies that diffused from the blood into the lung when you have a barrier leakage. And we made use of the fact that we have both modalities, or both body fluids measured. So here the serum on the y-axis versus the lavage fluid, the local fluid. And you can see proteins that highly correlate. So those are serum proteins going into the lung. But then you can see proteins that are highly enriched locally in the lung. They're also detected in blood, but we interpret this as a local production of these proteins. And this includes many antibodies. So specifically here, you can look in these red triangles. You have all these different V segments marking different antibody repertoires. And many of them are actually highly specific for COVID-19, and especially those local ones. So the blue ones, the non-local ones from the blood, they were actually shared across all the different pneumonia entities. So this suggests there's a local pool of specific variable domains of specific antibodies, B-cell clones that are specifically induced by COVID-19. We went to other independent studies where you have a VDGR profiling of the B cells and asked whether the same V segments, so the same type of antibody rearrangements, are associated with severe outcomes, which was indeed the case. So in our case, it's a very severe group of patients. And so this means there is a specific repertoire of the antibodies in severe COVID-19, and we could ask, okay, are these autoreactive antibodies? And we have previously developed this method where we capture antibodies from patient blood. Here in the first publication, we applied this to lung fibrosis cases. We capture the antibodies, and then we incubate the antibodies with a natively extracted protein extract from human lungs in this case, and then use mass spec to quantify the binding profiles. So you can identify autoreactive bindings. So this was validated with the clinically approved or clinically used ELISA test for, in this case, scleroderma autoantigen. These patients all had a clinically diagnosed autoimmunity, and that's the antigen. And we had almost 100% sensitivity and specificity using mass spec to arrive at the same result. But then you can appreciate in this volcano plot, we can detect all kinds of autoantigens, and it's kind of a multiplexed, unbiased experiment. Applying this to the COVID cohort here, again, same grouping, and we also measured autoantibody profiles at different time points. Same method, and also here we have kind of a proof of concept example. Some patients received tocilizumab, which is a therapeutic antibody against anti-IL-6R, and only in these patients we pull out IL-6R because these therapeutic antibodies bind to our beads, and then this was a good proof of concept that we are measuring the right thing. Then, of course, we can identify different autoreactivities. So here shown for two different comparisons. In the first cohort against bacterial pneumonias and against influenza. So those are the COVID-specific putative auto-antibody reactivities that are shown here. And we did the same for a cohort from Munich. And I should point out there's a very high heterogeneity, which is, I guess, problematic. However, there is some consistency. So we find many shared antigens in both cohorts, some of them immunomodulatory, some of them against complement proteins that we have heard earlier today. And many of these very significantly correlate with some of the clinical features. So this is, of course, way too complicated, but there's some interesting associations, as I'm showing here as example cases with the clinical outcome scores or some of the different blood parameters. So we have generally we have autoreactivities that are associated with a more severe or less or more detrimental outcome. And we also have cases where this seems to be the other way around. Having the antibody seems to be protective. So this is, of course, now the tricky part to interpret and to make use of these things. So as a summary, I have shown you that there is a persistent presence of a specific B-cell repertoire and associated autoreactive antibodies in severe COVID-19. We can use a mass spectrometry-based profiling for unbiased and highly multiplexed characterization of autoantibody profiles in long COVID. So going forward, I think that the application of this method may improve endotyping. So we have heard that some clinical trials didn't give the right results. I think it would be interesting to have this as an additional modality in some of the deep phenotyping efforts in the larger cohorts. And with this, thank you for your attention. I thank all the funders and happy to take questions.
Thank you, Herbert. I guess there are questions. If not now, I will start with one. So you find a lot of antibodies that are reactive with tissue, right, and tissue surfaces. Mm-hmm. Did you also find anti-cytokine antibodies, or was that included in your screen? First question, because many studies done on that find anti-interferon and anti-interleukin.
So by definition, everything is included what is in our pool of proteins that we extracted from basically the human tissue in this case. So in theory, we are offering a human proteome, which also has all the PTMs that may be needed for the antibody binding. Most of the proteins we find are intracellular, but there are cell surface receptors and in rare cases also some cytokines included. Yeah?
And maybe a second question in that regard, how are you moving on now? Are you trying to identify which of those autoantibodies are really binding antigen or eventually even neutralizing receptor activity or something? Like how functional are they?
Yeah, so by definition they are binding because that's how we measure them. We don't know about affinity and all these things, and of course we don't know which ones are causal in terms of exacerbating the disease, for instance. So in our ILD study we have found that autoantibodies against thrombospondin 1 in 2 independent cohorts were significantly associated with survival. Right. So that there could be some of these antigens also be associated with some clinical features. Okay, but thank you. Currently it's only correlation. Yeah.
There are a few further questions. Christina.
Thank you very much. Very nice data, and you very nicely showed the different potential antigens. My question is, you showed it in different diseases. Do you have an idea whether healthy individuals might also have a prevalence for clinically not relevant autoantibodies, so that it's a secondary event that the infection then drives them, or whether it's a de novo event that gives sort of a new autoantibody repertoire?
Yeah, that's a great question. So in the LD case, our controls were healthy age-matched individuals. So the assay is defined by the difference to these people. But then within the control cohort, of course, you can find outliers that have very strong bindings, and this could be subclinical in a way. Yeah.
Yeah, really cool. From the autoantigens that you showed, do you think that they're presented, or that it's molecular mimicry, so that the antigens, proteins you see, the autoantigens, are really presented on MHC? Or that it's just antibodies binding random, semi-random?
Yeah, that's a great point. I guess at this point we don't know. It's hard to say. So I guess in a tissue injury and repair context, the appearance of low affinity autoreactivities, even without a classical immune presentation, are possible. So I don't know. Yeah.
Time for one last very quick question.
Also a question regarding autoantibodies you may find in healthy volunteers. Did you find any signal regarding G protein-coupled receptor antibodies?
Yeah, unfortunately, mass spec is that's one of the limitations, that GPCRs often have lots of transmembrane domains, so they're a little bit harder to detect, and they are underrepresented in our analysis. So I think there could be great synergy between such assay with a more targeted assay for GPCRs. Yeah.
All right, thank you again, Herbert. And I'm handing over to Rembert Koczulla.
Thank you, Susanne. So it's a great pleasure to guide you through the second part of the session. And we now focus on lung imaging. And I ask Professor Claussen, Vogel-Claussen from Hannover, to come to the stage. Thank you for being here.
Yeah, thank you for the opportunity to present here. And the work we're presenting, there are like three main studies we did. Is interdisciplinary work. But as I'm a radiologist, you're hearing this through the radiologist eye. And I would like to introduce to you two technologies which we sort of established and partly invented in Hannover as part of the DZL funding, and we're very grateful for that, because without the DZL funding we wouldn't have been ready with that technology to image the lung function in the COVID pandemic. So I think this is great. So we have been really prepared and could roll out this technology. So what did we do? This is called pre-fall. With MRI, there's very little signal in the lung, and the lung looks dark, like here. But if you image over a minute and then go into the frequency space of the breathing and reconstruct a whole breathing cycle, you can see regional ventilation. And what you see here is inspiration and expiration. And you even see the trachea. Do you know why you see the trachea? There's only air in the trachea, you shouldn't see. But the trachea is moving, right, with the breathing, and that's why you see it. And then if you go in the frequency of the pulse of the heart, you can see during the cardiac cycle how the pulse wave, right, goes from the center to the periphery in the lung and backward. So what we're actually seeing here is not truly perfusion, it's the pulse wave, it's the fresh blood flowing in, and we reconstruct the whole cardiac cycle. And with that, I hope you're all researchers, a lot of lights go on and you can measure a lot of things. And this is what we did, and this technology, I have to disclose, gets productized by a large imaging vendor. And so we collaborated with them and brought the technology to Erlangen, where they had a brand new low Tesla MRI and tried this out, and they got very surprising results. They had 9 healthy controls, 29 patients with COVID, so kids, they were like around 11 years old, who recovered, and 25 with long COVID, so all more than 12 weeks out, 12 weeks to a year and a half. And they saw a lot of perfusion defects and ventilation defects here in even the recovered ones, right, as well as in the long COVID ones. And both were more severe than that. And they put all the two groups together because it was very new. Nothing much was known about that at that time. And they saw that even if it's out longer from COVID, these are the days, right? You still see ventilation problems, perfusion problems, but these are the two groups mixed to each other. Is it just from normal, right, longer period of recovery, or is it something else? I can tell you one I know for sure as a radiologist is a shift, because they did a low Tesla MRI and they had more noise. You see the healthy ones having a VDP of more than 10%. This is due to the noise. So you have to deduct 10% from all the data. Then you're probably right. There's a bias in there. But you can see here, even after a year, right, you see a VQ mismatch. So gee, we thought we have kids in Hannover as well. And we will do this diligently with a 1.5 Tesla, and we had a matched healthy control, age and sex matched, and we had a matched post-COVID condition cohort. They're around 14 years old. And the median was 30 weeks after a positive COVID test. And we could pick up, right, so some mild ventilation heterogeneity, but in the post-COVID syndrome, there was really a striking lower perfusion signal than in the healthy volunteers. And this was also in the numbers, right? This is the dynamic flow volume loop, because if you depict the whole ventilation cycle, you have a flow volume loop with each voxel, right? As you know from lung function tests, it's only tidal breathing though, it's not a forced expiratory volume. And you see it, and the cross correlation should be 1 in normals, and you see the heterogeneity here, but in the 27 it wasn't significant. But we had this very strong signal in the perfusion, right? We quantify it in milliliter per minute per 100 milliliter of lung, and you see this is normal here, 80, and it was close to half, right? In those post-COVID condition patients. And the heterogeneity was also affected. And then we said, gee, maybe this correlates to the symptoms. And the pneumologist had the BELT score and the symptom severity, and indeed, only the quantitative perfusion signal was related to severity of symptoms. And in the publication by Pöhler et al., we showed this, right? The BELT score goes down, the perfusion goes down. The second method I would like to introduce you in the short time is hyperpolarized xenon. With the first technology, you can do it. You can collaborate with us. We give you the app, and you're good to go. Here, you need a little bit more. You need a hyperpolarizer, and you need a dedicated coil. So it's more costly. But what it can do is that the gas doesn't only go into the alveolar space, it goes into the membrane and it goes into the blood. And due to the frequency shift, we can see and tease out the different compartments of the xenon in the alveolar space, in the membrane, and in the blood. And this is from our post-COVID cohort. We did a post-COVID cohort after hospital discharge, when they were negative with a negative COVID test. And then 7 weeks later, and then about 30 weeks later. And you can see here, this is the red blood cell signal, right? You can see that gradually the red blood cell signal becomes more. Here you see that, here's discharge, and this even baseline, this is about 12 weeks after symptoms, this is 38 weeks after symptoms. You see even an improvement here, while lung function test was not changed. And alveolar membrane function is improvement. The perfusion heterogeneity is going down in the capillaries. So this methodology, because it goes into the alveolar membrane, it specifically measures the capillaries. And the capillary blood velocity increased logically if you have increased, if you have less inflammation increase. And you have a worse membrane function 12 weeks out after if it's more critical or if you're in ICU. And it seems to be also having a T-cell signature, which is different if you're having a critical ICU stay or a non-ICU stay. And imaging correlates, the membrane function correlates with these cells, with CT imaging with the ground glass opacities and the DZL. So summing up, we're very grateful for the DZL, that we had the technology ready, pre-full MRI and xenon MRI. If you're interested after the talk, come talk to us. The post-COVID condition in children, 30 weeks out, and the symptom severity correlated with a microvascular capillary perfusion signal, and alveolar membrane function and pulmonary blood flow recovery depends on the severity of symptoms in the initial phase, whether you had a severe course in the ICU or not. In general, that showed our xenon data, pulmonary blood flow, and that's the good news, and regional lung function are back to pre-COVID conditions if you have a normal course within 38 weeks. But we know, all of us who are sitting here, that long COVID is complex and we need to study the long-term effects on morbidity and mortality, not only in the lung, but everywhere else, and that's why we're sitting here. Thank you.
I think we have time for one short question.
So the perfusion decrease in the children, was this homogeneously distributed or was this patchy? So is it more a general decrease of flow?
It was more general, in general. It was a little bit more patchy, but in general, the whole, and I didn't disclose, the children with the post-COVID condition had a higher heart rate to probably make up for it.
So
it was significantly higher.
Would fit to this preload insufficiency that we also found with having a lower blood volume in,
yes,
in the lungs.
I think so. And the filling, someone said earlier today, is probably impaired in them. So it'll be very interesting, based on these data, to do larger scale studies. And this technology I showed you first, you can do at your hospital, and we're more than willing to help you.
Great, thanks.
Was there a gender difference?
Sorry?
A gender difference?
There were too few. We couldn't do that, unfortunately.
Thank you very much. So it's a great pleasure to introduce the last session. And he will present long-term outcomes on the COVIDOM study. So, Jan, it's a pleasure that you're here.
Yeah, thank you very much for the kind invitation and also introduction. We still had an issue here with the presentation. So we need to, Vorträge, ist das hier irgendwo? Please excuse the delay. So thank you very much for the kind introduction, also for the opportunity to speak here. So on behalf of my colleagues that worked on the COVIDOM and the COVIDOM Plus study during the last years, I'm happy to present at least the concept of our study. It's an ongoing study, and we are in the middle of the analysis, and there's also some associated studies that are part and complementary of COVIDOM and COVIDOM Plus. So where did we start? We started actually in the year 2020 as part of the NUM Netzwerk Universitätsmedizin studies, the NAPCON studies. We had several layers of intensity of disease. So we had critically ill patients and also patients that were patients but did not have a severe disease, which then would be the COVIDOM study. And we started to think about this early in 2020, or I have to say my colleague Thomas Barmer and Stefan Schreiber and others from this network started thinking about what may happen following COVID. So they designed this study without knowing that a syndrome called post-COVID syndrome would exist. So this also explains the approach a little bit. And so we started with this in Kiel, Würzburg, and Berlin, recruiting patients following COVID infection, and ended up with approximately 3,600 individuals. And I will not call them patients because it's a population-based approach. So all these individuals were contacted following an infection via the health authorities. So they were not patients presenting themselves in the clinic. And this was then also embedded in the NUM and NAPCON technical setting with a lot of infrastructures, also regarding data management and other infrastructures as well. So there are several publications that already came out of this in the past, and I will try to focus on our findings that are also the basis for the molecular analysis that is currently ongoing. So what were the aims of this COVIDOM study in 2020? Actually, we wanted to identify and characterize phenotypes of post-COVID syndrome also with the question, is there such a phenomenon in 2020, since the first patient was recruited in November 2020. So this was really within the first waves of COVID, where we were still struggling about talking about what is COVID, what is the disease, how about a vaccine, for example, and so on. And then also one aim was to identify potential molecular markers and also to characterize the microbiome of potential post-COVID syndrome patients, and to identify long-term consequences of COVID-19 in general. So as you will see, we're still recruiting or having the follow-up of the study, not recruiting patients. So this is the basic organization of the study. So following the infection, at least 6 months after the infection, which was PCR proven, we then planned several follow-up visits until the beginning of 2025. And now we are lucky because we received funding by the BMG to continue follow-up for another 2 years at least, and we will be able to then have a follow-up of sometimes of 7 years, where we have a deep phenotyping of these patients coming from all of these 3 study sites. So I will mention my colleague Thomas here again, because he had a very, very heavy workload in organizing this, also within the pandemic, which was going on when while the study was happening. And we have this infrastructure now in Kiel, where we have this modular approach where each module represents one organ, so to say. So this lung organ, the heart organ, the otorhinol organ, and so on, where we then had specific phenotypic assessments, also neurology, for example. And the total duration of one assessment took 4 to 5 hours in general. So the first step was to develop a so-called PCS score, where we looked at the self-reported symptoms and subsymptoms, also with a lot of scorings and paperwork that the patients or the individuals had to do. And then we tried to actually derive, based upon these self-reported symptoms, a score that would also have the ability to graduate the severity of hypothetical post-COVID syndromes. And you can see here that the most frequent symptom was neurological fatigue, sleeping disturbances, where we also heard today the study that will start only now, where we are also involved, and exercise intolerance, and pulmonary symptoms were rather infrequent, comparably infrequent. This was then the distribution of the identification cohort from Kiel, what we call the Kiel 1 cohort. And you can see that, and then the following cohorts from Würzburg and Kiel 2 as well. And you can see that there is a frequency of between 15 and 20% of severe post-COVID syndrome symptoms, or what we think could be correlated with post-COVID in general. And there were also patients that had either no symptoms at all or mild to moderate. And with this score, we are now having the basis to then analyze all the molecular samples that we have. So we're now looking into transcriptional, cellular immunology, the microbiome, and other markers as well, also in collaboration with a lot of colleagues in Germany and mostly in Kiel, of course. And there was also another hypothesis, because if we now identified a post-COVID syndrome in general, which we are all working on here as well in a lot of cases, is there also a different post-infectious syndrome in influenza, for example, also having this as a control group, and we received funding to have the exact same approach for post-influenza as well, and we are starting to follow up these patients, and we're now able to recruit around 200 individuals, and now the health authorities are sending out letters to a lot of patients or ex-patients in Schleswig-Holstein now again, and this will also feed again into the agenda of COVIDOM Plus, where we will continue the follow-up. In terms of pulmonary function and dyspnea, we also had the opportunity to have lung function testing, diffusion gas measurements, impulse oscillometry, pheno measurements, and also we had, of course, the symptom-based scores. And this is only a teaser because the manuscript is being prepared right now. But I can already say that we did not observe a lot of impairment, pulmonary impairment, also in the group of severe, PCS severe patients. We had only quite impressive signal in the oscillometry data, and we will now characterize that in depth. I cannot tell you too much about this, but it's quite interesting also to look at the small airway impairment then, and we are also trying to match that with the ongoing transcriptional analysis, which we will hopefully present maybe next year. We just published a GWAS based upon this cohort. Although it's a small cohort for a GWAS, we still were able to identify a few polymorphisms that were correlated with PCS severity, and one that is also associated with inflammation, with gamma interferon. And we're now trying to further characterize that and put that also into the context of the transcriptional and cellular immunology that we are analyzing right now. So, as I said, this is ongoing, and we're happy to have the opportunity to have the follow-up of another 2 years, and then I think in 1 or 2 years we will be then able to present data of a 7-year follow-up to see what kind of consequences COVID infection had, maybe also in correlation with historic cohorts before COVID in general. And with that, I would like to thank you for listening, also thank the collaborators from the different sites, and in general all the people being involved. And here I would also like to thank Lennart Reinke, who is also deeply involved in the organization, and my partners Philipp Rosenstiel and Stefan Schreiber in Kiel. Thank you very much.
Thank you, Jan. Other questions from the audience? So I start. Have you seen differences at your 3 inclusion points? So difference in Berlin compared to Kiel or Würzburg?
There were differences, but they were not significant. So there was no bias based upon the selection side, no. Not really, nothing that it was really significant there. We had quite a few issues with the echocardiography that I have to admit, and the standardization process, and so I saw the data that was just presented. That would be very nice to take a look at that as well, but that is kind of difficult right now.
Are there questions in the chat? Okay. So you mentioned the oscillometry. So you did it with every visit? Or?
Yes. So one of the questions that we're trying to answer right now is also how is the resilience of the individuals, also in the context of the subjectiveness of the PCS in general. And another thing is, of course, the reversibility of these findings through time. So longitudinally, and the oscillometry findings were quite robust so far, and they could maybe correlate with disease severity in the beginning, which at least pulmonary involvement.
It means your interpretation is that there's something happening in the small areas.
Yeah. We're lacking radiology, unfortunately, in a lot of cases, so that is not perfect. It's not the perfect cohort still, but that may be an explanation.
Okay.
Thank you very much. Very interesting study. Do you also have the linked sequences of the viruses for each of these patients? Would be interesting to know.
No, that is a question that was arising quite a few times. Thank you, Nico. Most of these patients were recruited during the first 2 to 3 waves of infection, but we don't have the actual PCR because they received the letters from the health authorities after being reported. So that sample was not available, unfortunately.
Thanks. So I think we are quite on time. So thank you for your audience. Thank you, the speakers, for perfect talks. And thank you to the DZL for hosting this session. Thank you very much.
Welcome to the next session. My name is Hans-Georg Kreuslich from Heidelberg